right, so we're going to get started with our Woodfire session. We're trying something new this year. Dr. Rinnie and I are going to tag team Woodfire, and we're going to pass cases back and forth. And our panel, from me towards Dr. Rinnie, is Dr. Geinesman, Dr. Berg, and then we are very lucky to have two of Chris Wood's proteges here. So we have Dr. Abel and Dr. Karam. I don't think any of us have any disclosures relative to Woodfire. Dr. Rinnie and I discussed whether or not we would try to emulate Chris Wood and decided we would not. He had a very unique style of doing this, and we kind of broke the mold when we made Chris. So we're going to do our best to make him proud, but we're not going to try to be Chris Wood. And I'm going to start with the first case. So this is a warm-up. This is a 52-year-old perfectly healthy physician, planned to donate a kidney, and everything was coming through perfectly fine with his evaluation until they got a CT scan. I'll show you some of the representative images. Just focus on the right kidney. Okay, so let's start with Dr. Geinesman. What do you want to do?
Well, this is a patient who would normally be seen by my urology colleagues. I think an MRI.
That's why I asked you.
Yeah, I think an MRI and a biopsy, I think, would be what I would recommend.
What's the point of the MRI?
I think better characterize it, make sure this is not potentially an AML.
Dr. Berg?
I agree. Tissue is the issue. Biopsy it. It looks like it can be biopsied.
Okay, so that's not really fair. How about the urologist?
I'm going to go ahead and agree. I'm going to go ahead and agree on this one,
Okay.
with both the MRI and the biopsy.
I would observe it, if the patient's willing to do that, of course.
Okay. The patient is motivated to donate a kidney, and you can see there a needle going into it. I'm not sure what a MRI adds if you're going to stick a needle in it anyway. And sure enough, it's an angiomyolipoma. It's HMB45 positive. That's pretty much, a no-brainer. It is an angiomyolipoma. So this is a fat poor AML. So, Jason?
Yeah, so I have actually had this exact same patient, and I did a number 1.
Okay. Jose?
I'm not a transplant expert, but number 1 sounds appealing.
Okay. Medical oncologist okay with that?
Yes.
Okay. Yeah, that's actually what we did. We just worked with the transplant team, and when the kidney with the AML came out, we just on the back table did probably the easiest partial in the world, and they put that kidney in. All right, so like I said, that was a warm-up. You're not going to get off that easy the whole time.
All right, now we're going to turn to the actual cancer cases. So this is a 68-year-old African-American female, presents with some flank pain and 1 episode of hematuria, ultimately gets a scan that you see that shows a large left renal mass. You can see it there. No definitive distant mets on CT, although in the radiology report, stop me if you've heard this, several small pulmonary nodules and cannot rule out metastases. There's no old films for comparison. Past medical history is arthritis. She's on low-dose prednisone forever. Nobody really knows why. She doesn't have a specific diagnosis, but has been on it for a minute. Hypertension and hypothyroidism, a little bit of anemia, slightly reduced GFR from just medical comorbidities, but other normal labs. Jose, what do you want to do at this point?
Biopsy.
Biopsy her kidney.
Yes.
Okay.
Assuming the metastatic workup is all negative, I would
The workup
biopsy it.
is just CT, chest, abdomen, pelvis, and again, aside from these small lung nodules, which I'm not showing you, of course.
Yeah, the reason to biopsy it is the kidney still has its reniform shape. The tumor is replacing it. There's tumor thrombus going down the lumbar vein as well. I've seen that happen with sarcomatoid tumors, so I would love to know that information.
Is there a biopsy result that would change your management?
Do you want to open that can right now? Sure.
That's why we're here.
Yeah, if somebody has sarcomatoid RCC and has vein thrombosis, even though it's surgically resectable, I would have a good discussion with my medical oncology colleagues about systemic therapy before surgery.
So even in non-metastatic, let's assume these lung nodules are nothing, even in non-metastatic disease, you might give systemic therapy first for surgically resectable disease?
If it's sarcomatoid, yes. I know you and Brad are staring at each other, but yeah.
Well, I just never thought I would hear that from a surgeon. I'm shocked. Jason, what do you think?
Yeah, I have similar thoughts as far as getting a biopsy. I mean, with the hematuria, with the kind of odd-shaped, poorly marginated central tumor, it could also be a urothelial cancer, which we would probably even still do neoadjuvant chemo for. I think eventually what you're trying to tell us is we're going to take this kidney out, and I think we'll probably agree with that, yeah.
I'm not trying to tell you anything. Stephanie, any thoughts from a med? How worried are you about these lung nodules, right? We all read radiology reports all day. There's almost no reports without lung nodules, right? When do you, let me ask it a different way. When do you start to worry? At what size, number, newness, whatever, when do you start to say, you know what, this really could be metastatic disease?
Probably like between 5 and 8 millimeters.
5 and 8. It sounds like you just made up those
I
numbers
did make.
on the spot. Okay.
I'm using
That's
the
fine. That's not a
criteria for
criticism.
lung nodules of NCCN.
5 and 8 millimeters.
Between 5 to 8.
Okay.
I would take it out. I'm not a surgeon, but it looks like a good surgical tumor.
Okay. And would you do a biopsy first? Let's say the surgeon will say, I'll do whatever you want. I'm not worried. You can biopsy it or not. I'll do whatever you want.
I guess I would question the RV thrombus and the extent and how they could do it, but systemic-wise, you know, I would say I would try to. Looks like a cancer, so it seems like it should be removed to me.
Dan, what do you think what do you think about giving systemic therapy first? If the urologist sends this back to you, either because of a biopsy result or they say, you know, this is not resectable. I've never heard any of these surgeons say that, but let's say they say, this is not resectable. You need to give something up front. What are you going to give?
Yes. So first of all, I think the biopsy to rule out urothelial carcinoma may make sense to me. Otherwise, I think resection is good. I think it can always be metastatic disease, whether it's 0.5 millimeters or 8 millimeters. I mean, we just don't know. I think for locally advanced RCC, we certainly give neoadjuvant therapy. I tend to use IO-TKI. This would not be a case, I don't think that I would typically do this, but if there's a reason that surgery is absolutely not possible, the patient doesn't want it, there are some other sort of reasons not to proceed to surgery, I think we could try neoadjuvant therapy. The benefit, of course, of that may be that we understand what's happening to the pulmonary nodules. So if those nodules completely regress, I would start to really get worried that this is in fact metastatic disease.
So let's talk about that a little bit. I saw Brad smiling when you said it's not resectable, like he couldn't contain himself. So let's say you give your favorite IO-TKI, you do a scan at 3 months. This is a little smaller, a little more necrotic, so there's some response. It's not dramatic, and tumor thrombi are, sort of unreliably respond to our systemic therapy, in my opinion. But those 1 to 2 millimeter nodules, now they're not mentioned on the report. You don't really see them. A lot of times, I don't even see them anyway, right? The radiologist will mention it. I'm like, I can't find it. I don't know what they're looking at because they have better screens or whatever. But let's say you're 3 months in, a little bit of response in the primary, patient's tolerating as expected, but now those nodules are gone. Does it make you want to just keep giving systemic therapy? Versus if they're still there? I'm just trying to dig into that.
Right, yeah, I mean, I think I try to get to maximal response before then proceeding to surgery. So it sounds to me like what you're trying to say is that the kidney, the primary, is really not responding that much. I may give another 3 months. I think at that point, I'm guessing we're going to hit a plateau, and that's when I would again turn to my surgical colleagues and ask for a resection.
Okay, fair enough. You want to say something, Brad? I
have to break in here. Sorry, I know this is your case. I'm just going to challenge the panel. At least 3 of you mentioned urothelial carcinoma. Has any of you ever seen a urothelial carcinoma this big that doesn't have widespread nodal disease and widespread metastatic disease? I don't buy it, right? I have never seen a urothelial carcinoma that big that didn't have widespread metastatic disease. So have you? Any of you?
I think it's a fair point.
Just say yes, even if you haven't, yes.
No.
No.
I didn't say that,
exist,
yeah.
right? It does
I think
not
it's kidney.
exist. So
And the extensive tumor thrombus, right? I mean,
You can
get
rule
tumor
out
thrombi.
urothelial carcinoma just based on the fact that this patient doesn't have widespread metastatic disease.
That's true, but I think if you're going to give neoadjuvant, let's call that therapy, then I definitely would like a biopsy proving clear cell RCC.
for sure.
And again, I think the biopsy doesn't add very much morbidity. I think it's a very low-risk thing to do. You know right ahead.
I'm going to ask another question, if you don't mind, Brian.
Please.
For those that are operating, are you doing a node dissection? I'm going to point out something that I see on this, right? Can you guys see this here?
Yes. Kind of posterior to the aorta there.
I mean, that could be part of the cruciate diaphragm too.
It
So
doesn't
it's
look like cruise to me, but.
well, yeah, on one image, sure. But to clarify, this is definitely resectable. That wasn't the issue to give neoadjuvant therapy. But lymph node dissection, if there are enlarged lymph nodes, yes. If there aren't, no. And I know from the Mayo data that there is a correlation between the size and the sarcomatoid and all that. But unfortunately, most of the lymph node dissections that we do are not curative. So can we do the lymph node dissection? Sure, we can. Can we take the tumor? Yeah, sure, we can. The goal here is to try to give the best chance of cure for the patient. So if you ask if I do a full bilateral or a PLND on this patient at the same time, probably not. Not at this point yet.
Jason?
Yeah, I agree with Jose for the most part. I do think getting the information that somebody is node positive helps you make decisions as far as adjuvant therapy. And so, again, that could, if it's not the cruciate of the diaphragm, I think I probably would get that node. I don't know about a full bilateral RPLND because I think that does increase the risk of complications. But I would take out any nodes that were suspicious and definitely do a regional on that side.
All right, so patient gets a left radical. It's supposed to say clear cell RCC, not RDD. See the size, grade 3, pathologic 3A. There's some perinephric fat invasion. There's no note of sarcomatoid changes or necrosis. By my calculation from the Fox-Chase nomogram, it's about 40%. Maybe before we get into management, Dan, or for all of you, and I'll have you just come towards me in responses. What are you using Fox-Chase, or what are you using to estimate risk? Is it back of the envelope or one of these nomograms? If so, which one? And then how are you using that? I mean, do you think it's accurate enough? Are you giving the patient the number? Are you putting it in your note? Take us through that.
I am using the nomogram. I am using the nomogram from Assure, which is on the easily accessible on the Fox-Chase website. It's not as granular as I don't think anyone would like. I like the early disease progression of that nomogram to give me a little bit of a clue how aggressive this is. But I do use that nomogram with patients directly to have a conversation about adjuvant therapy. I think it helps to frame it.
Okay, Stephanie.
I agree. I use the Assure nomogram as well most often, but I want to comment that I would restage this patient because it seems like she has Mets, and if we offer her adjuvant pembro, we are under-treating her. So we would have to, I would wait a little bit and see after surgery, like what happens to her nodules.
Side question then, do you always restage patients before you start adjuvant therapy?
Absolutely.
You do it on the same day? You do it that morning, they get scans, come see you and get...
No, I mean, that would, wow, no, I hope so, but no, usually like a couple days before.
Okay. I do it just that morning, unless I'm super worried. If I'm super worried, I'll do it a few days before, because that's an uncomfortable conversation when they come in to get adjuvant therapy, like, oh, by the way, it's not adjuvant.
Right.
Yeah.
This one I'm super worried. I would make sure that I...
Fair enough. Jason?
Yeah, I don't use the nomogram. I do think the prominent limited predictive accuracy of any of the staging makes it difficult. I think it's a nuanced discussion. I think there's a lot of different opinions as far as which patients benefit, and we like to talk about the adverse events a lot too. I think surgeons probably like to talk about that more than maybe the medical oncologists, but
wait a minute.
just saying. But I think that it's a nuanced discussion. I mean, I think this patient may or may not benefit.
Yep. Jose, in terms of nomograms, estimate risk.
Just like the rest of the panel, I use the Assure. It's very easy to use it as a link through the Fox-Chase website in Epic, so it's very easy and convenient to use.
Okay. And then yes or no to finish up the case. You're going to give this patient a year of adjuvant pembro based on that risk. Remember, it's like she's on a little low-dose prednisone. We're not really sure what's going on. Renal function's 58, so it's normal-ish. Jose, we'll go back this way. Just yes or no?
No.
No, you're not going to offer it.
I will offer it to anybody who qualifies for it, but I wouldn't try to
You wouldn't push it in
convince
this
them or
patient
push them.
because why?
Because the risk is
too
I don't want
low.
to say it's only 40%. It is a significant risk, but
Fair enough.
the short answer is I will discuss it with them, but I will not try to push it or convince.
I got you. Jason?
Yeah, very similar to what Jose said.
Okay. Stephanie?
I would offer, we have the at Farber, we have the vaccine trial open, so
Okay,
that would be
clinical
interesting.
trials, not an allowed answer. That
Oh,
was a Chris
man.
Wood rule.
It's choice D. I would offer it. And we'll discuss and offer it.
There's always the discuss and offer, and then to Jose's point, there's the you should really do this, right? Those are a bit versus, yeah, you could get it, but then you emphasize side effects, right? You can steer the patient if you want, but you would steer her strongly,
I would steer her strongly to use. To get it.
just based on the 40%
Yeah.
and your concern. Okay, Dan, last.
This is tough because of the nodules. That makes me uncomfortable because I'm worried that I may be under
So you rescan on day one, and the nodules are still 2 millimeters, and the radiologist still says suspicious for metastatic disease. And the patient has read the report before you walk in the room because it popped up on their portal.
Yeah, so with that report, I would be less likely to recommend adjuvant therapy. I would prefer to observe this patient and use the most effective systemic therapy when necessary.
Okay, fair enough. I think we could probably move on.
Let's move on to the next case. So this is a 57-year-old, presents with hematuria and complaining of pelvic pain. He doesn't really have much for past medical history, and he gets a scan for his hematuria evaluation. So you can see this CT of the chest. There's a few pulmonary nodules. They're fairly small, but they look real. I'll just highlight a few of them here.
Can you go faster, please?
Sure. Can you see that, Jose? Am I going slowly enough for you, Jose?
We're
Do you
good.
see that pulmonary nodule, Jose? There's a few more here. I expect the medical oncologist to be better at this. You see that one?
There's a nice one.
A few there. So that looks real to me. He's got this very destructive bony lesion here. And he's got this renal mass here. I'll give you some more pictures of the renal mass. You can see there's a tumor thrombus in the IVC, level 2. So he's got a 15 centimeter heterogeneously enhancing renal mass, level 2 thrombus. I'd say small volume, but real pulmonary metastatic disease, and what I will term a nasty pelvic bony and soft tissue lesion. So, what do you guys want to do next?
Biopsy something.
Biopsy something.
Biopsy is soft tissue lesion probably. It has a soft tissue component.
Okay.
But not for divergent histology, I'm not a pathologist, but hopefully we could determine that because sometimes these more aggressive divergent cases can, with the thing. So, number 1.
Okay, number 1. Anybody not want to biopsy this?
Biopsy is good.
Yeah, I'm good with it.
Dan, you're okay with that? Okay. He has a biopsy. This is read as just high-grade clear cell. No sarcomatoid features, no rhabdoid. I'll give you these options now. Jose?
The systemic therapy. Is the patient symptomatic from the bony lesion?
He is.
So I would probably do radiation and then initiate
Okay.
systemic therapy.
Jose? Thank you. Jason?
Yeah, I think I would do the radiation to the bony pelvis, and then I think I would do cytoreductive nephrectomy in this patient.
What systemic therapy are you guys going to give?
I-
No, that's for you two at the end, the surgeons.
If I want to sound smart, I would say cabo-nivo because it's involving the bone, but
Okay?
whatever my
You sound
medical
very smart to me,
oncology.
Jose. Thank you.
No, I'm not going to go ahead and agree with Jose on that, but I think I would do the surgery first just because the patient is symptomatic and is bleeding, and I can probably fix that. I think
Okay.
the very small volume disease in the lung is compelling.
I think I would agree for surgery for the pain and the bleeding because with our IOTKI, I would be concerned about side effects.
So the pain is coming from his pelvic tumor,
We
not from the kidney.
We could ask for NSAIDs, pain meds, radiation for surgery.
Okay. Dan, we have one urologist that wants to take it out. We have one that wants to give cabo-nivo.
So, I mean, this is at least an intermediate risk patient. I don't have all the values. It may be poorest.
So let me just ask. what do you need there? I will tell you his labs are remarkably normal with the exception of anemia.
Yeah, so he's got 1, 2, so I guess intermediate risk, I don't, performance status, I'm not sure what it is with all the pain. I think that if you can control the hematuria quickly through some ablative technique potentially, I would prefer to start with systemic therapy in this patient as soon as possible and defer surgery. I think if you cannot control the hematuria and you have to do, this is really then a palliative, I would say, surgery rather than necessarily cytoreductive one, that's fine.
Okay. Well, he's had 1 episode of hematuria. It resolved. He did get SBRT to his pelvis, and he was started on Ipi/Nivo. So after 2 years of Ipi/Nivo, that's when we actually get to see him, and he has evidence of progression at this point. So he's progressing sort of everywhere. What do you guys want to do now? I'll spare the urologist this one. So Dan and Stephanie.
Yeah, I mean, I would use single-agent TKI. I would use cabozantinib in this case. Next line. Outside of a clinical trial.
Yeah, I would go cabo for him.
Single agent cabo. Okay. This was a while ago. He was put it on Pembro-Axi, and after 6 months of Pembro-Axi, he comes and visits me for the first time, and his chest looks like this now. I'm sorry, Jose is moving fast, but I will tell you those small pulmonary nodules are still small. No real worsening of his pulmonary disease. This is what his abdominal imaging looks like. He's actually had a little bit of a response in his tumor thrombus. If you recall, it was higher than that before. It's much better defined. He's had sort of stable disease in his primary tumor, which you can see is definitely extrarenal there. So, what's next? Are you satisfied that he's doing okay and we should just continue his systemic therapy?
Hey, Brad,
or?
remind everyone, his response to the Pembro-Axi was what? Stability or?
Stability, maybe a little bit of a reduction in his tumor thrombus,
Okay.
and stable in the chest. Ever since his radiation, his pelvic tumor appears to have been stabilized and he has no pain. His performance status is great. He's got an ECOG of 0 now.
So I think I normally would wait a bit more just to be sure that we're going the right direction. Maybe wait for about another 6 months and then do a cytoreductive nephrectomy and IVC thrombectomy.
Jason, you wanted to operate in the beginning. Are you going to wait longer now?
I still want to take that kidney out. I think that's the right thing to do.
Okay.
Can I ask, Jose, are you worried that you're missing a window here, right? Because the average response to single-agent TKI is probably not going to be a year, right? So if he's at 6 months doing well, let's take the Pembro out of the equation. You know, are you worried that you're missing a window? Or you're like, well, if he's going to progress, he's going to progress systemically and then...
Yeah, the number 2. I mean, the
Yeah.
question is if we're racing with metastatic disease and have a window of a few weeks or a couple of months to do surgery, in my mind, we're not going to benefit the patient with that operation. I worry more about the metastatic disease than the local disease. The local disease, like Jason said, it was resectable at the beginning. It's still resectable now. I worry about what's happening outside the kidney.
Fair enough.
Okay. Stephanie?
I think if he's fit, it sounds like surgery would be, that's why he probably saw you as a surgeon. So I think that was the question. I would urge surgery.
You okay with that, Dan?
I would not do it yet. I think it's, he progressed in Ipi/Nivo. It's been, you said 6 months of Axi Pembro. I don't think the Pembro is probably doing anything, and this is axitinib probably controlling the disease. I'm worried that if we go to surgery, we stop the TKI, this is a big operation. He doesn't get back on systemic therapy for a while. He may have rapid progression. I'd like longer control before I think about cytoreductive nephrectomy, especially since he's asymptomatic.
Okay. So you're worried that the surgery is morbid in some way? That doesn't make sense to me. I'm just kidding. Okay. So we had a 50-50 split. So for those that wanted to operate, Jason and Stephanie, what if the original biopsy had sarcomatoid features? This was something that Jose brought up on the first case, or the first cancer case, Brian, the second case, yeah.
I mean, he got Ipi-Nivo, so that was,
He did,
yeah, that's good.
but he didn't really respond. So what if,
I mean, I thought he had 2
do you
years.
still want to take it out at this point is the question, if we had found sarcomatoid features on the original biopsy with stable disease?
That's an aggressive pathology, so yes.
Yes, okay, Jason?
Yeah, I still want to take it out.
Jose, would that make you even less likely to take it out?
It would make me more likely to wait more.
Wait longer. And Dan's nodding his head. Okay. The reason I ask is, as Stephanie alluded to, he was sent to me from a medical oncologist for surgery, and I said, that sounds like a good idea to me, and I took it out. And even though our biopsy didn't show sarcomatoid features originally, there were sarcomatoid features in the final specimen. And then 2 months after surgery, I think Dan alluded to this, his pulmonary nodules are progressing. I will tell you, he is disease-free in his belly, and he was only in the hospital for 3 days, Dan. It's now 2 months after surgery. I thought, well, we'll give him a chance to prove to us that he's going to do okay, but he's proving to us he's not going to do okay, so he's had some progression there. So bone is still stable, belly is free of tumor. What's next from our medical oncologist?
I would try belzutifan.
Belzutifan.
I mean, I think that's certainly very reasonable. I think because he has not had cabozantinib, that's an option. So is lenvatinib with everolimus. I think there's not one right answer in this particular case.
I mean, I might just put him back on Axi, right? He didn't,
it was working, right?
progress on Axi. There was some evidence of response. He hasn't failed it yet. It hasn't failed him. So I would probably save my other bullets, for later.
Glad we have consensus. Okay.
All right. Fourth case, the 75-year-old male, good performance status, has some type 2 diabetes and hypertension. This is a year and a half ago, has a CT for some reason showing that renal mass that you see, some lymphadenopathy, gets a bronchoscopy with biopsy of one of those hilar nodes, and he has a poorly differentiated carcinoma, but it's consistent with kidney cancer. Dan, how would you approach this patient? You get another biopsy because you're not satisfied with that pathology report? You're going to treat systemically or sort of like multifocal local therapy, I guess would be the other option.
I'm not sure I would get another biopsy. I would believe that this is RCC. I would make the assumption that this is sort of an aggressive clear cell RCC. It may not be, I understand, and proceed probably with systemic therapy in this case.
And what would you give?
IO-TKI in this case.
Which one?
I'm sorry, what's that?
Which one?
Axi-Pembro, probably, in this case, why 75-year-old? I like the ability to really modulate the dose of axitinib to small doses. I'm worried about tolerability. I think any of the three combinations certainly have level 1 evidence, and so I think it's fine to use any of them.
So you're picking based on tolerability, not because this biopsy is a little unusual or anything like that?
Say it one more time.
You're
I'm sorry.
picking based on tolerability, not because the biopsy is a little bit unusual.
Correct. I
Yeah,
think in this
okay.
case, yeah.
Fair enough. Stephanie?
Agree, the biopsy is not satisfying at all, but he does need systemic treatment. So I would go Len-Pembro and just watch his blood pressure. But eventually, I would want to know for second-line treatment, like, can I use belzutifan? Because, we can't, if it's mostly clear cell, I'm not going to do it. But if it's a divergent,
So you might rebiopsy down the road for that
Down the
reason,
road.
but no,
Correct.
not
But
going
yeah,
to
'cause
change your
in the front line,
management
it's all-
now, in
correct.
essence. Okay. Jason, what do you think? You want to take this kidney out, give you more pathology, right? Get a big chunk instead of a little chunk.
So, what is the metastatic disease burden? Is it just
It's really what you see on the bottom right there. It's just some nodal disease. You see like a right hilar node, maybe a subcarinal node, let's say. Not high volume. There's no old scans to know the pace of disease, which is always helpful, of course.
Yeah.
So it's not a lot.
I mean, I'm tempted to take that out and maybe try some local therapy. I mean, again, maybe defer the systemic therapy for some time. But by the way you're asking this question, I'm guessing that's going to be wrong.
There are no wrong answers here, no wrong answers. But how much, I think it's a reasonable approach, but how much disease outside the kidney or how many sites would make you say, no, that's not a good idea?
Yeah, so more than 2 sites or 5 centimeters of disease. We had published on that specifically for immediate cytoreductive nephrectomy. That corresponded with patients, being alive at 1 year. So the patients that didn't progress rapidly were those patients.
Okay. It's like a debate. We've cut off Brad's microphone.
I feel like I'm in a debate. I was muted. Jason, the MD Anderson data says mediastinal lymphadenopathy is a reason not to do upfront cytoreduction. You don't buy that?
Yeah, so no, we looked at that again in a larger cohort, and that didn't come out as a predictive factor. Okay. I do think, in patients with a few mediastinal lymph nodes, sometimes, the thoracic surgeon, or sometimes you can even radiate these depending on their location next to the heart.
Jose, what do you want to do?
Probably go systemic therapy route. I don't know what this patient's kidney function is, or the 75-year-old will end up.
It's as expected.
As
what do you want it
usual?
To be? Yeah.
52. But Jason's approach is reasonable as well, to operate and then radiate the hilar one, but I would favor systemic therapy.
Would everyone favor sort of nephrectomy and, let's say, SBRT to nodes? Like, is there an age? Is the age sort of pushing you towards systemic therapy? What if the patient's 65, 55, 45? Dan, do you have or does age not matter here?
There's probably some line where age matters. I don't know what that line is, but I don't think it's...
That's what I'm asking. Huh? What is that line? That's what I'm asking.
I don't think we should look just at age. Honestly, I think I've seen, we've all seen, extremely robust 85-year-olds and extremely unrobust 60-year-olds. Okay. So I think it's really the fact that systemic therapy gets us a chance to get sort of the kinetics of this. It's a good litmus test. We can decide about local therapy thereafter.
Fair enough. Brad, you want to click? So this patient does get systemic therapy, gets Ipi-Nivo, gets all 4 induction doses, has some sort of normal stuff, grade 3 rash, actually grade 3 colitis, was admitted, but got steroids and did better. Now on Nivo maintenance, just has some mild arthralgia, so actually sort of doing well. Next slide. And so here's the scans. This is actually about, I don't want to say it's like 14, 16 months on therapy. So the mediastinal node's not kind of well shown here, pretty much resolved down to normal size. But the kidney is, as you see it kind of looks the same as it did before. So patient's doing well, right? Clinically well, a little bit of arthralgias, not on steroids, functional, et cetera, et cetera. Call the nodes resolved in his chest and has this kidney left. Jose, do you want to take this out, do cytoreduction, just continue systemic therapy, or radiate the primary?
I think this is a good time to go for cytoreduction.
Okay. And then, sorry, one more question. What would you do with the systemic therapy afterward? Would you put him back on Nivo or stop?
I would give him a break and then see how
Just image
it goes.
and see what happens?
Yeah.
Okay, fair enough. Jason, what do you think?
Yeah, no, I agree with that approach.
Stephanie?
Yeah,
Patient's doing great.
Yeah, you wonder
Doing
when
great.
it comes out, it's probably going to be all necrotic maybe.
ECOG 0,
Yeah.
couldn't be, running
Take it out.
marathons, whatever, doing his thing.
Take it out.
I'll
Give
send
him-
him
But
to
you still-
Brad.
what's that?
I'll send him to Brad. There'll probably be an outpatient surgery with him. So.
It'll be a drive-by. And Stephanie, would you restart systemic therapy? So you take it out, it's whatever pathology you want it to be. It's very typical, let's call it.
Yeah, or it's all dead cancer or necrosis.
Sure.
I think he's had a good, he's had a good response in NED, so I agree, wait,
You would-
scan, yeah.
Wait, scan, and at progression, figure out what to
Yeah.
do. Fair enough. Dan?
Yeah, I agree. I think the reason to do surgery is to give somebody a treatment-free interval. So I think this is the time to do that and not to give therapy thereafter until you need it.
Fair enough. Anybody want to radiate anything? We need a radiation oncologist on the panel next year. That was a...
Well, I think it's not that you have to radiate, but I think given the recent data, I think SBRT could very well control this, and I think this is a discussion with the patient, and if they do not wish to undergo surgery but still want local therapy, I think radiation is an option here.
Okay, fair enough. Brad, I don't remember what's next. So it does go to cytoreductive nephrectomy. It's actually a papillary with sarcomatoid features. And so kind of the same question, but really does that pathology, does the sarcomatoid features especially make you want to resume systemic therapy or not? We'll just go quickly down. Jose, does that change anything? You'd still give them a break?
Yeah, let's just wait 6 weeks, rescan, and go from there.
Okay.
Yeah, I agree. Wait 6
Same.
weeks.
I agree.
Sarcomatoid. Just asking.
He got Ipi-Nivo again.
features. What's that?
He got Ipi-Nivo, so.
Okay. Just asking. Dan, anything?
Yeah, I mean, obviously there's a viable malignancy still. I'm worried this gentleman is going to recur, but I think we've made the decision, and I think we sit tight for now.
Quick question for the medical oncologist, Dan, starting with you. In this circumstance of consolidative nephrectomy, do you always restart systemic therapy? Do you always not restart systemic therapy? And then and also, does it depend on if there's stuff left behind? So let's say he had, I don't know, some 4 millimeter pulmonary nodules or something that you thought was disease, but it was just hanging out. Would that influence?
I try not to restart systemic therapy. I try to time the surgery when we can give a break. Again,
Yep.
that's a big, I think, positive for,
Great.
for that approach. But there have been cases where we do restart. A lot of times, I think, based on patient strong preference to do so and worried about progression. But I try not to.
You're right. So you're
Can I augment that question with, does it matter how much necrosis you see in the tumor when it comes out?
I mean, I think, I'm not sure I have data to back that up, but I think if it's mostly necrotic dead, I feel certainly much more comfortable not to restart it versus a lot of viable malignancy still left behind. Just
It's a data-free zone, yeah.
I think so.
Stephanie, anything to add?
I think it was just something, because it's a papillary, it's a non-clear cell type. I think giving a break and just seeing and letting it declare itself afterwards, if it's such low burn disease. The lymph node mediastinal radiation, that can be tricky for toxicity afterwards for patients if they can get really good fields, but
Agreed.
that's something maybe later to do too.
Okay. So the pathology really didn't influence management, amount of necrosis, sarcomatoid. We still want to give a break and then just watch. Okay. I think we're next.
All right, I'm going to skip this one because we've kind of beaten this topic to death already. Brian, can I skip this one too?
Oh, wait, what happened?
No?
Sure. Yeah, go
Okay.
to that one. We can always come back.
Let's try this one. So this is a 69-year-old woman sent about a year and a half after she had a lap nephrectomy elsewhere. The pathology report from that was grade 2 papillary, 9.3 centimeters, T3A, NX, MX, R0. And she shows up with this scan. All right. So there's the pertinent images. So, Dan, you're smiling.
I'm a happy person. I think given the papillary pathology, given that our systemic therapy certainly is not as good in divergent histology, given the isolated recurrence, I would argue for surgery here.
Okay, Stephanie?
18 months post-lap surgery, I would urge. I agree.
The medical oncologists want to operate. What do the surgeons want to do?
Typical, right? No. I agree. I think if it would be a lot nicer if it was like 3 years post, but I do think you'd get the same way.
Short answer is I would operate at this point if there's no metastatic disease elsewhere.
What histology would change your mind?
If it was clear cell, I would probably less inclined. But for these, I don't know what term we're using these days, but for papillary or chromophobe, if it's isolated in the retroperitoneum about a year and a half and beyond, it's probably a good idea to do surgery.
And Jose, you're less inclined in clear cell because the systemic therapy works better, or for another reason?
I think biologically, from retrospective studies we've done, it seems that there is a higher potential for a cure with local surgical therapy in this localized retroperitoneal nodal disease in papillary or chromophobe versus clear cell.
Gotcha.
In clear cell, it seems the lymph nodes are more indicative of M1 that's going to happen.
Fair enough.
So, Jose, this patient's in your clinic. It's a clear cell, it's a papillary, it's a chromophobe. In each of those situations, what are you going to tell them the likelihood of prolonged disease-free survival is going to be with a node dissection in this setting?
I would quote from our study, which again is small retrospective, about 37% chance of durable control with surgery alone.
Papillary or chromophobe?
Yeah.
And what about for clear cell?
I don't have good numbers or data for that.
Jason, do you?
Yeah, I would agree with the 30, 35% for the papillary, the chromophobe. I think maybe about 15% if it was isolated, 10 to 15% if it was isolated clear cell.
In our data for isolated clear cell, it's 5%. So the likelihood of hematogenous Mets, if you have nodal recurrence with clear cell, is super high. Okay. So this is what happened to him. He had a node dissection, or she, sorry.
I want to note it took us 57 minutes to get to these gross pictures in Brad's cases.
It turned out to be actually a chromophobe on our pathology, and this is the data those guys referred to. So we have 3 minutes left. Do you want to do one more?
Yeah, let's do it. Let's crank.
You want to do the one that was before this one?
No, just do this. Do this.
Okay, this
Oh,
is
this is
an
a good
interesting
one.
case. 42-year-old, very healthy guy, sent to our medical oncologist after he had a left radical elsewhere this year, and pathology revealed a SDH deficient, SDHB alteration. And the question of our medical oncologist was, is there any additional treatment this patient should get? So I'll ask Dan and Stephanie for SDH deficient RCC. This was a node positive, single positive lymph node in the para-aortic region, T3 tumor. No evidence of metastatic disease.
Yeah, I mean, this is a tough one because I think there are certainly, I'm sure, very, very few, if any, patients like that on Keynote 564. I think outside of that, you would consider certainly adjuvant pembrolizumab for somebody with a positive lymph node, young. I think this is a situation where you would consider it. I think in this case, I'm not sure there's good data either way, but I think that you could consider adjuvant pembrolizumab in this case, but I'm not sure, I'll be honest.
Okay,
Not
Stephanie?
sure.
I would say right now I would monitor. I don't know if I would offer pembro, but this is a germline mutation or this is a...
He's got a germline mutation.
Okay.
So he saw Lance Pagliaro, who re-imaged the patient, and you can see he's missing a left kidney. Do any of you see an abnormality in the left panel? Because our radiologist said this was a normal scan.
Is that a liver lesion?
No, it's not.
What is that?
What? I can't
What's
hear
going on around
Lance.
the splenic vessels? Just
Okay.
can't tell from that
I'm going to
image.
make it obvious.
Yeah.
Right here.
Yeah, what is that?
Right.
See that?
What is that?
That is a retrocrural lymph node.
Yep.
Yeah.
So, what do you do next?
I mean, for a 42-year-old with an isolated lymph node, if this is something you can get to, I mean, those locations, to my understanding, are challenging oftentimes to resect. I would try to resect, or as my urologist call it, to resect if possible.
This is how far out from surgery now?
He's about 6 months.
Yeah, I would not resect that. If
Okay.
it's real,
So-
I would recommend either systemic therapy or radiation.
Do you
But
have good systemic therapy for SDH? I think the two medical oncologists weren't really sure they had anything.
well, that's for the adjuvant setting, though.
I think they're
Yeah.
still not
Okay.
sure, though.
So I'm gonna just throw out something that I find fascinating. We have to know this again. So he's got an SDH deficient tumor. FDG PET is broadly completely useless in kidney cancer because a lot of renal cell carcinoma is not PET avid. But FH deficient and SDH deficient RCC utilize a ton of glucose. So FDG PET is really good for imaging these people. So actually what I did was I got an FDG PET, and the only thing that lit up anywhere in this patient was that lymph node. It's actually not that difficult to get to, Dan.
This is for me.
The main thing is when you cut through the crus of the diaphragm, it balls up on either side. You have to let your radiologist know. They will see some thickening of tissue here. So here's aorta. The cava is pulled aside up here. And this was where that lymph node was sitting. And I went down below his right renal as well. And we are out of time, so thank you very much to the panel. Appreciate your participation in Woodfire.
Thank you.
Thank you. I would drop that for sure if I was up here. I'm really humbled, and I couldn't believe it when I got the email that I had this award. But I just wanted to thank KCA and everybody for this. So I'm going to talk about me a little bit. I was born in Minnesota. My father and mother were both educators. My father was an elementary education professor, and my mother was an English teacher, but she also had a master's in creative writing, and she was a Fulbright scholar. And I have two brothers, and we moved around a lot. But most of my life grew up in northwestern Ohio, in Maumee, Ohio, which is outside of Toledo. When I was a little girl, my father took us to El Salvador, working for USAID on sabbatical, where he was setting up teacher education. And I also spent time in Southern Africa, and I have to say that my experiences there were really eye-opening about how the rest of the world lives and the disparities and how fortunate we are here in the U.S. I was always interested in healthcare. When I was in Lesotho, when I was a junior in high school, I went there rather reluctantly because I was a junior in high school. But I did my school through correspondence through the University of Nebraska that year. And because it was a very quiet area of the country, there weren't a lot of kids around my age that were, that I, in my status or whatever as a white person living in Southern Africa. I just didn't have a lot of friends there, but I had the opportunity to work for Save the Children. The upper part of the slide here are some of the children in Save the Children that I worked with. And I also was working with the blood bank at Queen Elizabeth II Hospital in Maseru, Lesotho. And my boss, Setso Moela, who is holding the flowers there, really taught me a lot about, we'd go into the mountains and collect blood for blood banking, and I learned a little bit about cross-matching and how you do that by hand. I went back, finished my senior year at Maumee High School, and I was accepted into a 6-year BSMD program at Kent State, and what was then Northeastern Ohio University's College of Medicine, in which they changed the name to Neomed, and this is my daughter and I visiting colleges. That's Kent State, and that's Neomed just in the last couple years. I had two mentors in high school, Roland Skeel, who was very active in ECOG and was at Medical College of Ohio, and Dr. Warren Kleinberg, who was a pediatrician, who I thought was really interesting because he had spent time in Sudan. From there, so why did I choose oncology? So I'm going to show you my family tree, which I drew out by hand here. My father and mother were both Mennonites, and they were distantly related. And this to the left is my father with his father. He's the little boy there. Why is his mother not in the picture? Because his mother died of metastatic breast cancer when he was 5 years old. And my mother is on the right here, the little girl whose father is holding her hand because she wouldn't sit still. And they both came from very large families. You can see on there that there I am, and my parents both had polycythemia vera. My father had a head and neck cancer when he was 29 years old. His mother, I said, died of breast cancer. His father died of GE junction cancer. His sister died of had breast cancer and then died of GE junction cancer. My mother's sister died of pancreatic cancer. And 3 cousins, first-degree cousins in her family, all had pancreatic cancer. So cancer is very personal to me. I was really afraid of cancer, and that's really why I went into oncology. So here are the lines showing that. And after my residency, I went to Fox Chase Cancer Center, where I did my fellowship working with non-coding DNA. I thought it was very interesting to be in the lab. I never had a lab experience. I don't think I was very good at it. And I couldn't get funding because at the time they didn't think there was a role for non-coding DNA. So from there, I always took care of patients, and I really liked taking care of patients. That was really where my passion was. So when I was at Fox Chase, I became involved with ECOG. It was ECOG at the time, not ECOG Akron. And I was very fortunate to be able to lead a phase 3 study that you're all familiar with, which is the ASSURE trial. And this trial accrued over almost 2,000 patients. It wouldn't have been done without the support of all of the people that are here and many other people. I would just point out that on the bottom left is Bob Coombs, who was a patient advocate at ECOG, who was really involved in providing feedback about trials, and we included him on the paper with the publication. And then Judy Manola, of course, is next to him, and she's a statistician who was both very instrumental in ASSURE and also in the PROSPER trial. Now, although the almost 2,000 patient trial did not show a benefit in disease-free survival, I do think that it is really an example of a highly effective way to learn about translational science. And I did want to highlight some of the papers that have come out of this. This is Harriet Kluger, and she very generously created an 850 patient tissue microarray, which has been really valuable for her and a lot of other collaborators. 600 of the patients had clear cell histology, and in this particular authorship, she showed that high tumor microdensal density was associated with improvement in overall survival. You were all talking about the ASSURE nomogram, which really heartened me, and I won't say much more about that except that it was really built on almost all of the patients who participated in this trial, including central review, and it's both histology and stage agnostic. The Rupal Bhatt and Vince Zhu and Mike Atkins with the Dana-Farber SPORE, Harvard SPORE, were very supportive of this trial. This is some cytokine work that they did in 413 patients and in CXCL10. This is the kidney injury 1 stuff, and I just want to emphasize, and I'm very proud that the ASSURE trial was really the first trial that the analysis was done and showed both a correlation with high KIM injury 1 or KIM1 levels with both overall survival and disease-free survival, and also correlated with stage. And as you know, this has now been used in both Emotion 010 and Checkmate 914. So I'm going to move on in the interest of time, but I think that the correlatives can really help define subpopulations of patients. From there, based on Chuck Drake's preliminary data showing that priming the immune system ahead of surgery might be a useful way to approach, we embarked on the PROSPER trial, which was led by Lauren Harshman and Mo Alaf, and many other people supporting. That's Deb Maskins in the bottom there, and Mike Carducci. And we couldn't have done it without the SUO and all their sites. And although we didn't see a difference in recurrence-free survival, I think that everybody is very interested in the platform. This is the first trial that we were able to show that it is feasible to do a neoadjuvant perioperative trial. I want to just spend the last few minutes talking about work at Penn. And I want to point out Giancarlo Mazzolini, who is to the left here. He was an engineer. He was a patient of mine that I met at Fox Chase. He lived for 18 years with metastatic clear cell renal cell carcinoma. And he's standing by his elevator that he designed that goes up 3 stories, and it's based on a vacuum cleaner power and uses pneumatic pressure to lift the elevator. His generosity, philanthropic support sponsored the first Italy-Philadelphia convergence on renal cancer, and Bill Kalin, who was invited to speak 2 days before, won the Nobel Prize. He was still really, it was wonderful. He still showed up to participate in the conference, and we were grateful. These are some of the things we're doing at Penn. It's just wonderful to have Phil there as a urologist. That's Ketelan Sustek, who is a physician scientist who works in chronic kidney disease. We started after the AACR kidney conference, we started Kidney Day and invited everybody we could think of at Penn who was involved in kidney cancer research there and at CHOP. We ended up with more than 30 people, and we've started basically a regular retreat, which has really spawned a lot of research ideas. We put in 4 DoD grants, and I just can't tell you how much I enjoy working with these people and Celeste as well. So my second to last slide is just that in the last week I've been appointed as the overall GU chair at ECOG Akron, and I hope to continue both the research that we're doing at Penn, but also to continue to work with the GU group and in ECOG Akron, and to accelerate some of the efficiencies and things in the clinical trials, and to mentor investigators. And this is our patient advocate, Glenn Sykes. He's on belzutifan for metastatic disease, and he was in Bolivia, and he texted me to show that his pulse ox was still 85 degrees, or 85% rather, at 16,000 feet. And finally, I just want to thank the Kidney Cancer Association, and this is my family, my husband Peter, my daughter Aisling, who's a senior at the University of Vermont, is not going into medicine, or at least that's what she says, and me. And thank you very much.
All right. I haven't given one of these before, so bear with me. If I could have the next slide. Where are the slides anyway? Oh, can I have the next? There we go. Yeah. Humanitarians. So when I think of humanitarians, you know, I really think of these people who are saints, these people that go in times of need to help people, and they do it, you'll see here, every single one of them with a smile on their face. And, you know, they bring their expertise, they bring their time. It's very personal, humanitarians. They work directly with people. And they really rise to the call. And I think about like who we are in cancer care, and you know, the truth is we're all humanitarians in what we do. It is a service. It's a service field, and it's very much a rewarding field for that reason. But I like to think of all of us in this award. Oh, that'd be great. Thank you. Nick, though, was the consummate humanitarian. You know, when I think of what an oncology humanitarian would be, Nick really kind of checks all the boxes. I mean, he absolutely loved trainees. He absolutely loved working with colleagues. I mean, he loved the science of the field. He loved the progress and the clinical progress. But most of all, he loved the patients. And not just his patients. Nick loved all patients. I mean, people would call him up or would run cases by him, and he always had ideas. I really first met Nick when I was part of CLGB, which is, again, sort of what Alliance used to be. And it was a much smaller group. Then Nick was really our first chair for GU oncology in CLGB. And I remember meeting this guy, and, you know, he's a big, tall guy, and he, you know, just had a big smile on his face all the time. And I remember feeling like, you know, you're never going to live up to these people, you know, Phil Kantoff, Eric Small, and Nick, and others. And, you know, he was one of the first people to say, you know what, welcome to the club. And it really kind of inspired me. It gave me some confidence to persevere and stick with research and stick with academic medicine. So I really thank Nick for that, but most of all, just for being a role model for this next generation, my generation of medical oncologists in GU. Oncology, I like to think of as a relationship-intensive field. This actually was not my term. It came, actually, I'll talk in a minute about this resiliency coach that we hired for our group, but it really came from Patrick. And I asked him, like, what do you mean by that? He said, well, when people get cancer, they're hungry for knowledge, but they're desperate for relationship. They need to feel like you care for them. And it's true. I mean, what our patients really want more than anything is to know that, we care for them. And I kind of embrace that. Some people might push away from it, and I can understand why, but I've always embraced that. And to me, it's been very, very fulfilling. And just pictures of me with patients over the years. But the truth is that it's also a burden. Patients are living longer than ever before. Our therapies are working, and then they stop working, and we have more lines of therapy to offer people. But people get sick. People have complications, and at some point, that relationship can cloud our judgment in terms of what's really the right thing to do next, another line of therapy or supportive care. And those discussions are hard. And it doesn't matter how long you've been in the field, they never get easy. But it's what we do, it's what we have to do. And I wouldn't shy away from it. I lean into it with my colleagues. And it's to me, it's still one of the most rewarding things we do. But it is a burden, and there is risk of burnout. What do our patients really need from us is hope and reality. And I say those two things because I don't want to say they're opposites, but they're sort of they're yin and yang of the same circle. And the truth is that, we're excited about the progress we've made in the field. There's so much that's going on and so much to talk about and to hope for. And yet, on an individual basis, it doesn't matter if a therapy has a 90% chance of working. If you treat enough people, you're going to have the 10%. And, patients need to feel that hope. If it's the other end of the spectrum, if we're giving a therapy in the third line and there's a 10% chance of a really good response, they got to feel that. If we can't convey it, they're not going to believe it. So that hope is important. But it's got to be balanced with the reality. And the reality is that we don't know where they're going to be in that spectrum. And they're not a percentage. They're not going to get maybe they'll get a 30% response, but they're not going to get like, a relapse or a non-relapse in the adjuvant setting. It's going to be one or the other. It's critical for us to be humble enough to recognize that we don't know what's going to happen to them when we start them on a therapy. But confident enough to say, no matter what happens, we got your back. And that's the truth. And even if it's not necessarily the result we want, it's something we're all trained to deal with. And that's really ultimately what our patients need. And we need to take care of ourselves. It's a long road out there being an oncologist, and I've been in it for over 20 years now. And I take care of myself, as Tian said. I like to be active. I like to keep moving. I like hiking. I love swimming. I'm on a swim team. I don't compete that often, but it's mostly the camaraderie. And I like to vacation. I like to bike. And you see a lot of this with my family and friends. It's really important that you have some healthy habits. We have to sleep. We have to eat, right? We have to take care of ourselves. Because if we don't take care of ourselves, no one else is going to do it for us. And we're not going to be in shape to take care of patients. And if we're going to talk to patients about lifestyle, about diet and exercise and sleep, what credibility do we have if we're not doing it ourselves? So it's really, really important that we take care of ourselves and prevent that kind of burnout. It's also important that we do this as a team. So I mentioned this resiliency coach we hired. It was right around the time of the pandemic, just before. And we brought him in because, I won't say we were dysfunctional, but we were probably not optimally functional as a group, and you can always do better. and I recognize that, we can do better collectively, and, individually we were successful, but Patrick really helped us kind of reorganize our team meetings, give voice to some of our other members so that those loudmouths like myself weren't dominating the meetings. And it really just, I think, helped us grow as a group. And then the pandemic hit, and it was so important that we had that sort of team unity. We don't work in a vacuum. We are so dependent on our staff in order to be successful. And our best resources, our really most key resources, are our people. And that loyalty is so important to me, just what Tian said about, building up everybody in the group. It's really what makes work special, what makes us functional and effective. And along the way in these meetings, we kind of came up with this idea of a day of remembrance. This is our meditation room that we have at our Cancer Center at Duke, and the fifth Tuesday of every month. So our meetings are always Tuesday. Well, when we have a fifth Tuesday, it's an extra day. So on that fifth Tuesday, we meet in our meditation room, and we just go around as a group, a doctor, a nurse, an NP, and we talk about the patients that have died. And we don't talk about them in front of the patients. We talk about them about ourselves, and we, sometimes it's funny, sometimes it's always a little bit sad, but mostly it's personal. And the things we learn about each other and our relationships with patients have been great, but most of all, it's just made us all closer together. We do a lot of team building. I like events. I like to have fun, as Tian said. We do all kinds of group meetings and parties and events, and it's important to vary them because not everybody can come to everything, but pay attention in your group to the people that aren't participating in any events. Those are the people that you really need to reach out to. And now, since the pandemic, with all the hybrid work, we're meeting less and less. These kind of events take on a more critical meaning to sort of helping people feel aligned with our mission. It's not just a job that we do. And lastly, I want you to think outside the box. It's my only data slide here. And we work locally with our teams, with our patients, but kidney cancer, it's a national problem, it's a global problem. I'm just looking at it from the US here. But I want to point out something. On your left is the age standardized cancer mortality by county in the US. This is a Herculean paper, if you get a chance to look at it. 4 decades of looking at cancer mortality across the US, and then tying that with Census Bureau documentation for each county across the country. And what you see are hotspots of where people are dying from cancer, and it's in Appalachia, it's down the Mississippi, it's in the Southeast. It's kind of where you might think we have the least amount of access and education and resources. So that kind of makes sense to me, and you can see some areas where there's just not a lot of people, and East and West Coast pretty well covered. But then you look at kidney cancer, and kidney cancer looks very different than the rest of the cancers altogether. In kidney cancer, we're seeing this density of, we still see some Appalachia and down Mississippi, but in Louisiana and Texas and Oklahoma, high burden of cancer mortality. What is that, right? Because we've got the access issue that we see on the left, but it's more than that, right? There's something in the environment in these people that they're living in that's exposing them, not just to getting kidney cancer, but dying from kidney cancer. And so as humanitarians, as oncologists, to thinking outside the box, it's really up to us to be able to say, what are we going to do about that? How can we study as a country, what are the issues here? And it's going to be challenging, but groups like the KCA give us a platform to think about national issues like this. And I would encourage us all to really think about things we can do, because this is what we're up against. This is another study, but it's also looking by county at cancer-related facilities in the US. And what you see is, again, across the Southeast, the Mississippi, and again, in big chunks of Texas and Oklahoma, there are huge areas, counties by counties, of no cancer-related facilities. What does that mean? That's a medical oncologist, that's a radiation oncologist, right? Those people only work in cancer-related facilities. So you might have primary care, might have general surgery, or even a urologist, but you're not having the resources. And that's going to be a problem for us, but That's something, again, on a national level, KCA can really, really help with. And I'm just going to end with a thank you to the KCA because, this meeting wouldn't happen without the KCA. This is the KCA's meeting. They are the workforce that puts that behind the scenes that makes this happen. And it's really an unbelievable opportunity for us to gather as a field, a multidisciplinary group, and come together. It's so important that we support the KCA, that we support these meetings, and that we build on them, because we can't take this kind of resource for granted. And to be the humanitarians we want to be and think outside the box, the KCA really gives us a platform for that. So thank you so much. And I'm going to say all advocacy groups, because Dean is here, and KC Cure is right there. I mean, there's honestly, all the advocacy groups in kidney cancer. We couldn't do it without you, and we need to do more. But this is really it's a really great community, and I'm so proud and grateful to be part of it. Thank you all so much.
So we just wanted to thank everyone, and we hope that you really enjoyed our program this year. It was a lot of work from all of our committee members, and of course working with the wonderful Kidney Cancer Association. So we just wanted to again thank Dr. Simon. I don't think she might have taken off a little bit early again, but what an enjoyment her talk was yesterday about targeting metabolism. And then a quick, again, shout out to our wonderful award winners. Again, amazing, truly kidney cancer field experts. And again, one more thank you to our sponsors and media partners listed here. Again, this meeting is a partnership, and we're so grateful to everybody. And then just for a little bit about CME, again, just make sure, please fill out the evaluations. It really helps us plan the meetings moving forward, and what you thought, what could be better, what we did really well, it's always important to see that. And this is a QR code for your CME certificate. I'll leave that up if you wanted to get that. Oh, there's an arrow. Go ahead.
Thanks, of course, to the Planning Committee, and thank you so much to the faculty. Wow, another fabulous meeting. This is definitely far and away one of my favorites. This community is amazing, and I'm blown away every year by where we're going with this cancer. And most importantly, we hope to see you again next year. In May, the European version will be in Amsterdam, and it should be beautiful. And this meeting will be in Colorado. We're moving west, and first time inching our way to California.
I think that's it. We're going to close. Thank you so much, everyone.
Thank you.